All right, on to our next fearful dementing illness. So, frontotemporal dementia or frontotemporal degeneration. So, in contrast to Alzheimer's disease, we're going to have a younger population, so onset in their 50s. Relatively speaking, memory is spared, although it can get affected some. But you're going to see a lot of personality changes in this patient population. So some of the personality changes that you can see in FTD, so you'll have disinhibited reckless behavior. So patients out of the blue start picking up a gambling habit or don't dress up or forget to go to work, things like that. They'll have stereotyped ritualized behavior. They have something called a catchphrase or gramophone syndrome, where they just keep saying the same phrase over and over again, often out of context as well. Because of a relative loss of inhibition, they'll also have a preference for sweets because they've lost that inhibition to have their dessert first. So they'll jump to dessert before having the rest of their meal. And they might even start hoarding items as well as they develop their diagnosis. FTD comes in three classic phenotypes, and they can be tricky to think about, especially when you see them for the first time. So it's important to be aware of these three variants because it will make it easier for you to make the diagnosis when you see these patients in real life. So the first one is probably your classic one that you hear about the most, this frontal variant. So that's primarily behavioral changes that you're seeing. So apathy, disinhibition, poor hygiene, those are the lead symptoms that you're seeing. The next two are going to be related to language primarily. So the first one is going to be primary progressive aphasia. You'll have this effortful, non-fluent speech. So think of it as your FTD taking up shop first in Broca's area before spreading out. The next one is semantic dementia, and that's sort of the, not quite the opposite, but it's going to be the Wernicke's variant of your frontotemporal dementia. So the comprehension is going to be affected first. These patients also will have difficulty with naming things and have something called associative agnosia, where they have difficulty recognizing objects even though they're able to actually perceive or even draw those objects when you describe and show them to them. So the pathology for FTD, your classic pathology, we call it Pick's disease pathology. You're going to see these Pick bodies, we see them here, these dark blue spots, these inclusion bodies, and then these Pick cell, these pale swollen neurons over here as well. And then some people will refer to the brain will have this severe atrophy of the frontal lobes and sometimes the temporal lobes. And this very sharp atrophy, some people call it a knife's edge atrophy. So frustratingly, especially with these pathology findings that we see down here, that only happens in about 15 to 20% of patients with FTD. So only 15 to 20% of patients will have this classic, what people used to call Pick's disease pathology. In fact, when I was going through medical school, we used to call this Pick's disease, but we modified it over the course of time to refer to Pick's disease primarily as this set of pathological findings, rather than just the clinical findings that we just talked about. All right, let's talk a little bit about Huntington's disease, and then we'll jump to a couple of Parkinson-like diseases. So Huntington's disease has really three cardinal features that I think about. So one is a set of motor findings, most commonly chorea, which is slow writhing movements, almost worm-like slow movements, and they're often subtle. Patients will try to even hide them if they feel like they're developing. The next thing you'll see is some psychiatric findings, so depression, impulsiveness, psychosis. And then the third thing is you'll see some dementia to go with that. Genetically, you'll have to remember Huntington as the gene, which is easy to remember, but this is associated with an expanded triplet repeat, which can get bigger and bigger with each generation that inherits this gene. So it's an autosomal dominant inheritance, and that finding is called anticipation. So if someone has 40 of these repeats, their children will then have maybe 50 or so. And the more and more repeats they have, the more severe or the more likely that person is going to have the diagnosis. Pathologically, one of the things that you're going to see is this loss of the caudate nucleus, if you remember that structure. And then we have this finding that a lot of people refer to as boxcar ventricles. We'll show that in the next slide. And what you're seeing here is basically this loss of the caudate nucleus leading to this enlarged lateral ventricles here. They don't really look like boxcars to me, but what can you do? So let's talk about dementia with Lewy bodies, which is another neurodegenerative illness associated with movement disorders. There's three primary features with it. One is Parkinsonism. So there are movement disorder features that look a lot like Parkinson's disease. There are fluctuations of attention and their cognition. And there's also well-formed hallucinations in a good majority, over 80% of these patients. There's also some supportive findings. I think the one that I want you guys to really pay attention to is something called REM behavior disorder. If you've never heard of it, basically it's the acting out of your dreams, so that these patients have a loss of the normal sleep paralysis during their dream state. And so the patient themselves doesn't recognize that there's anything going on, but their bed partner will say, oh yeah, they've been kicking and screaming in their dreams during their dreams for years. That finding actually has a high association with an eventual development of dementia with Lewy bodies. So that's something to watch out for. The next thing we'll mention is what some people call a Parkinson's plus syndrome, corticobasal ganglionic degeneration. So this is a sporadic disease, not much of it, no genetic component associated with this. Onset is usually in the 60s. And so we're thinking about three things. One is Parkinsonism, sure. Dementia, sure. But really the main thing is this unilateral limb ataxia. So basically there's like one arm or one leg that's just not behaving itself. The one thing that these patients can often experience is that affected limb with the apraxia will start to develop something that some people call an alien hand or an alien hand-like syndrome, where it just assumes postures and positions without the patient even realizing that that's happening. And because they're unaware that that's happening, that's why we often refer to it as an alien hand, alien limb syndrome. Let's next mention vascular dementia. This is probably a disease that gets suspected more often than it actually happens. As it turns out, so what you look for when you're looking for vascular dementia is a stepwise decline in cognition. And what we're thinking happens is that basically you have the accumulation of many small strokes that eventually lead to this dementia happening over time. As it turns out, though, when you do pathologic studies on patients who we think have vascular dementia, a good chunk of them actually turn out to have Alzheimer's disease. So really you're looking for a history that's consistent with many small strokes and this stepwise, we call it decline. So each time suddenly they lose a little bit of cognitive ability, and then it happens again, and then it happens again. The next thing we'll mention briefly is a little bit different than what we've been talking about. It's a prion disease, so Creutzfeldt-Jakob disease. But I think it's worth keeping in mind it's associated with something called a rapidly progressive dementia, which is one heck of an oxymoron. But these patients start to develop dementia like we've been talking about over the course of months, sometimes weeks. They also have two other features. So one is myoclonus, and then the last one is an ataxia as well. The other set of features that I want you to really pay attention to for right now, for your purposes, are the pathological findings, the spongiform encephalopathy that a lot of people refer to. So if you look at this slide here, there's a lot of space there, a lot of cells that are lost. And this is an extreme example of gross pathology of the spongiform encephalopathy. I will say that on MRIs, and in the clinics, when you see these people in the hospital, you're probably not gonna see anything to this extreme. But in the testing world, they may ask you about the spongiform encephalopathy. Another finding that you might hear about, although I've never seen it, is this weird EEG pattern where you have this 1 Hertz periodic spike and wave happening throughout the entire EEG record.